is basically go through a little bit of getting to know Medicare in general to begin with today. We're going to do a brief recap on some of our previous weeks, and if you've been joining me over the last 2 or 3 weeks or so, we've been really kind of touching on how to prepare and get ready for the upcoming 2019 AEP, well, rather the 2019 Medicare season with the AEP just around the corner here and just over a month away. It's hard to believe how fast the time is flying, but it is always good to prepare now. Hence the reason that we've been doing those initial couple weeks of just real preparing things that you need to do to make sure that you're ready to roll once October 15th hits, so that all you really need to do is pick up the phone and or get on those one-on-one meetings and get rolling. So what we're going to do today real briefly as far as our agenda is concerned is we're going to really again touch on basics of getting to know Medicare in general. What is Medicare? Why should we be selling it? And again, if you've joined me over the past couple weeks, we have touched on these. So it's just going to be a real quick overview, brief recap on those subjects themselves. We're going to touch on some of the enrollment periods, obviously with October 15th coming up, and then the new OEP that's been reinstated as of this year for 2019. And then we're going to dive into the wonderful world of Medicare as far as Parts A and B are concerned. So these are the exciting lessons for me. We're going to go over some coverage, including exclusions, things that are and are not covered. A couple different ways that you can really get signed up and actually get Medicare rolling. And then we'll definitely also touch on, premiums, deductible amounts, any cost sharing amounts and things that are included within each parts as well. And then some brief info on enrollment and payment options. So again, if you didn't already hear, I definitely wanted to see if everybody could grab some paper. We're going to do a quick exercise or two once we get into parts A and B. I do encourage you as the broadcast unfolds, if you do have any questions, go ahead and pop them into the questions box, or if you run into any technical issues or just, as far as any questions pertaining to this specific material or any questions in general, feel free to stick those in the questions box or hit me up via chat. Of course, we do always have the training email, training@ahcpsales.com available for follow-up as well. So, one of the main things that we've been touching on over the past couple of weeks is really kind of getting ready to sell Medicare, why sell it, and some of the main reasons why selling Medicare itself is just an amazing product to put into your entire repertoire of items that you could or may not be selling. One of the main reasons that I really find encouraging, especially with the NatGen team, I'm very, very proud to be working for this organization. I have actually worked with NatGen now for just about a total of over 3 years or so. I had my initial stint about 2.5, 3 years ago in that aspect, and then took a small hiatus. And then, as fate would have it, it led me back into the family again this year as one of the Medicare trainers. So I'm very honored to be part of this wonderful, strong family. And just looking at the graphic here, we have entities that even as most recently acquired that go all the way back to the late 1700s, the early 1800s. So knowing that you have a really strong family behind you and the resources that we have available within our training teams, anybody in your upline, anybody within your direct area specifically where you might be at throughout the United States, it's really a good group of family organization that's going to be having your back, and basically any resources that you need are going to be there for the taking if you do happen to need them. So it's a really good thing to keep in the back of your mind as Medicare season unrolls, that you're really good. You're a strong part of just an amazing family here with the NatGen team. So jumping into the Medicare topic itself, what we kind of went over briefly in the prior weeks is we did touch on what generally is Medicare for starters. Medicare in and of itself, as far as what would be defined as quote unquote original Medicare, entails parts A and B and possibly part D as far as medication prescription drug coverage as well. And then there's also, of course, its own little animal in part C, which is the Medicare Advantage plans, which take all the parts of A, B, and C and combine them into one easy easy to utilize and easy to have plan. So Part C and D, as far as a shameless plug is concerned, we're going to be going over next week, and then in the weeks to come as well too. We'll also discuss some Medigap and some other areas as far as Medicare is concerned. But really today, to start with, we wanted to really briefly recap why you should actually consider Medicare as a product to sell. One of the main points that I've been trying to kind of get across over the past couple of weeks is just the pure simple fact of the amount of population that's available and eligible for the Medicare product themselves. So the statistic that I've shared over the last couple of weeks is that a person's really aging into Medicare just about every 8 seconds. According to the graph that we're looking at here, just looking at 2030 in general, 1 in every 4 are going to be 65 and over. That is an amazing field of leads to pull from. The baby boomers themselves obviously are largely responsible for this increase in the older population as they begin to turn 65 around like the 2011 range. Even looking at by 2050, the surviving baby boomers will be over the age of 85 at that point. There's going to be a total of around, 85 million at that point. That's just an amazing amount of just staggering numbers to look at. The thing to really consider out of that section of the population, though, is this little portion here, and I say little really kind of with a grain of salt, in the fact that just last year alone, according to CMS statistics, there were almost 4.8 million individuals, 10% of the eligible Medicare population, that had no supplemental coverage at all. So if you think about that in the other terms, I mean, you almost have 5 million individuals that were out there waiting for your call to get signed up in order to get covered that they were eligible. So, notwithstanding the fact that that is just an amazing number of individuals that are going to be qualifying for the product, and that in turn, of course, is going to be leading into residuals year after year after year when they need to renew their coverage. Also, the new age-ins, as well as anybody that's going to qualify for special election periods and things. But notwithstanding that, the ability to work with a segmentation of the population that's just a really rewarding portion of the population to work with. I know that every time that I talk with an individual in this demographic, it's a wonderful experience. Now, it is true that they might take a little bit more kid gloves at certain aspects. There could be a hearing issue, there could be some sort of a communication gap or a barrier that you need to overcome initially. But once you dedicate the time and you're dedicating the individual time to those enrollees at that time, making sure that you, of course, do your full and needs analysis, and that, as the saying goes, you're doing right by them, they are going to reward you not only with those residuals, but also be rewarding in the fact that they're an amazing group of people to just work with and talk with in general, but also the fact that by word of mouth out there, they're going to give you those referrals that you need of other agents and other individuals that just might want to switch the individual agent that they're with. So it's a really rewarding product on multiple different fronts, financially, and I use the word loosely, but spiritually too, internally, spiritually, that it's a really rewarding experience in and of itself. So with the fact that you have all of these numbers of individuals that are aging in, you might want to ask yourself, well, when can I start selling it? Obviously, the buzzword that's been coming up with AEP coming up just around the corner, and again, just over a month away now. It's amazing that the time is going by this fast. But October 15th is going to be when the AEP period opens, and that's going to be when you're going to generally do your annual enrollment period through December 7th, with their coverage effective date to the 1st of January. Now, keeping in mind, though, the nice thing about this, though, is that if you're choosing to use Medicare as a product to add to your sales repertoire, or just even sell Medicare by itself, this is a product that you can sell all year long. Notwithstanding the October 15th to December 7th window, you've got the other window of time after December 7th, starting on the 8th, all the way through the following year into October 15th of the next year, that you can actually do enrollments all year long. So, in that general period, you're going to have enrollments basically 12 months out of the year. So this is a really a product that's going to be something that's going to sell itself as the year moves on. So what we're going to dive into today Again, we're going to really focus heavily on parts A and B today. And again, next week on next Wednesday, we're going to jump into parts C and D as well and give a good deep dive into those two portions. But really today, we're going to focus on those first two parts of what original Medicare really entails. And that's going to be Part A with its inpatient care and the nursing and hospice home health care portion. And then of course, Medicare Part B with its outpatient and doctor's insurance. So with that said, we'll dive right on into Part A today. Part A is going to be the majority of your hospital inpatient coverage. So the real easy way to differentiate Part A and Part B is Part A being anything that's going to be inside or internal in a hospital in a unit of stay for any extended period of time. Defined as far as Medicare Part A is concerned, it's going to help pay for their inpatient hospital care, their inpatient care in a skilled nursing facility, including any home health care and hospice care as well too, underneath that umbrella of Part A coverage. The coverage itself, as far as Part A, generally starts after a 3-day minimum inpatient hospital stay. So this isn't just going to be going into the ER and then being released. This is going to be if there is a considerable injury or considerable accident that is going to require services and supplies medically necessary in an inpatient portion of a stay. So after that 3-day minimum inpatient stay, that is when Part A is going to kick in and start taking effect as far as its benefits are concerned. Now, the inpatient stay, as far as the way it is calculated, those 3 days start the day that they are formally admitted. So that's when that countdown begins, on day one that they're admitted into the hospital. So admissions, sometimes, I mean, they can be stuck down into the ER or in any sort of an initial phase of getting into the hospital, but that's going to be once they are formally admitted into the hospital itself is when that 3-day period is going to start counting down. Included within that, as far as the hospital is concerned, that's definitely going to include any daily skilled care or IV injections for things like pain medication, any sort of infectious IV medications as far as antibiotics of that nature, and or even any physical therapy that's needed while they are on an inpatient status within the hospital itself. Additional things that are actually covered underneath Part A. Now, if you take a look here, item number 1 does have a little asterisk next to it, meaning the fact that Part A, by definition, does include a semi-private room. Now, a lot of comments are made and it's out there, well, what about HIPAA? You don't really want to be having a doctor stand next to you and explaining your medical needs when there's somebody just a curtains move away to your right or to your left in the hospital bed next to you. Generally speaking, about 98, 99% of the time, they generally do have their own room, but if the hospital, let's say, due to certain aspects, if there's overcrowding, it does at least at its minimum and at its core cover a semi-private room. While they're staying in the hospital, of course, they do have to eat, so those hospital meals are covered. And any sort of skilled nursing and care and special units. So for example, if they have a really dramatic accident and instead of just, going through the ER normal route and then being admitted, if they're put right into ICU or if there's a surgery of some sort, that's going to cover the special unit care under that umbrella of coverage specifics. Likewise, any drugs, medical supplies, equipment that they're going to need on an inpatient status are going to be covered under this Part A, including, of course, lab tests, x-rays, and as far as like cancer treatments and things of that nature, any radiation treatment as well. Again, always as an inpatient coverage. It does include, like I mentioned before, so if there's an operating room need or if there's recovery room after the operation, those are going to be covered. Some blood for transfusions in hospitals or within those skilled nursing facilities, as well as the fact that a lot of the times when they're in an inpatient status, they're going to be needing rehabilitation and rehab while they're there. And that's going to be including things like physical therapy, either received in the hospital or possibly even through home health care if a physical therapist is going to be doing it in that aspect. So likewise, you're going to have skilled health care in your home if they're homebound, for example, and they only need, for example, part-time care, right? Or even care to manage symptoms and control pain for things that would be under the umbrella of hospice care or if they're terminally ill. Now, in that aspect of the coverage, you might ask yourself, so what's the premium for this? Most of the individuals are going to be getting Part A coverage without having to pay any sort of premium. You might hear terms thrown around like freemium or free premium. I personally don't ever like to use the verbiage, the fact that they're going to get Part A entirely free. There is the possibility that there is a cost. However, most individuals, as long as they or their spouse or the significant other in that aspect of their state status, as long as they paid Medicare taxes while working for a specified period of time, they're going to get that Part A premium covered for them. Now, what does that specified duration of time mean? What that means is that the way that Medicare determines the breakdown of this is that an individual earns what's called a credit every 3 months. So out of the year, there are 12 months in a year. Basically, that divides itself into 4 sections of the year. So every 3 months, 1 credit is earned. And by the time that that year is up, they're going to earn a total of 4 credits for that year. Part A is determined to be free once they reach 40 credits or 10 years. Just wanted to really quickly stop. It looks like Brenda, you're having some issues as far as audio is concerned. Everybody else able to hear me okay? Just give me maybe a thumbs up or something. I'm gonna unmute a couple people to make sure. Hey Ray, I got you unmuted here. Are you able to hear me okay, sir? Okay, I appreciate that, thank you. So I'm not sure, Brenda, what might be happening. If you wanted to maybe end the session and maybe jump back in as far as the audio is concerned, maybe give that a try. But also keep in mind, I do post these later on. We're going to have an area where I'm going to let you know where you can go to post to hear these as well too. So again, to get back into the premium portion as far as the credits are concerned, they're going to earn those 4 credits for the entire year. Once they reach what will be 10 years worth of paid Medicare taxes while working, they're going to earn their 40 credits. That is going to then qualify them for the free portion of their premium. Now, individuals who don't qualify for that free portion, they will have to pay a monthly premium of up to approximately $422. So what does that actually entail then as far as that 422 is concerned, right? So anything under 30 quarters, again, 1 quarter being every 3 months, you're going to basically earn 1 of those credits. Anything 30 and under, they're going to have a premium amount of $422 monthly that they're going to pay. But anything between 30 to 39 quarters, they're going to have a $232 monthly Part A premium. So there is a cost associated, of course, anything under that 40 quarter free premium portion. But so anything less than 30 is going to be at that high end of 422, and then from 30 to 39 quarters, it's going to be a 232 premium. So pretty easy in that aspect, right? Now, along with the premium and with just about every insurance plan out there that there is, unless of course you're on some of the platinum plans where there is 0 deductible, there is a deductible that's going to be $1,340. That's the most current number that CMS has given out for the deductible for Part A. So that $1,340 deductible is for each benefit period. What does a benefit period entail? That basically means each individual session that they're going to be inside the hospital is going to be that benefit period. So it is possible that there's multiple deductibles that would be paid at that point. But if you take a look at it and break it down at this point as well too, initially, when their first hospital stay comes into aspect, they're going to pay that first deductible up front for the first 60 days that they're in the hospital. So right up front, they're going to have that deductible that's paid. After day 60, going from day 61 to 90, it's going to be a $335 per day, again, for each benefit period. And then there is a $670 per lifetime reserve day after 90 days has been reached. And that's up to 60 lifetime reserve days. Inpatient mental health and psychiatric hospitals are limited to a 190-day time frame, so that does have a limitation in that aspect. So let's kind of look at this also from the skilled nursing facility. In and of itself, it also has what you would consider to be a deductible as well. So let's say that they get out of the hospital and then they have to go into a skilled nursing facility. So for their first 20 days in that facility, it's not going to cost them anything. However, after that 20th day, on days 21 through 100, it's going to be $167.50 per day. So it can get a little spendy in that aspect if there is an extended stay in a facility. But the good news in that aspect is that anything else above that, of course, is going to be paid through the Medicare Part A coverage. And then anything after day 100 are costs that are going to be owed as well too. So I mentioned at the beginning of the broadcast that we're going to do a little bit of a scenario here for you. So what we're going to do, go ahead and grab your pens and papers, and if you want to, you can pop in some answers into the questions box or even into the chat box as we go along here if you come up with a total. But I'm going to give you a bit of a scenario, and we're going to see, based upon those deductibles and those amounts that we're going to actually be looking at, what an average cost of a hospital stay would look like. So let's take a look at our scenario here. So Mr. Trumpet trips and falls. He's stepping onto his private helicopter and he is promptly rushed to the hospital. Unfortunately, it's determined that he has a severely broken hip. So in and of itself, what it's going to entail is about a 90-day stay in the hospital. It's a really bad break. After he gets out of the hospital, he's going to be transferred to a skilled nursing facility where he's going to stay for about another 40 days to finish his rehabilitation. So taking into consideration those deductible amounts and those costs per day, if you were taking notes, what are we looking at as far as the totals are concerned? So I'll give everybody a few seconds here to maybe do some quick calculations. I know for me, math is just a wonderful subject that I try and stay away from at all costs. But in this aspect, let's go ahead and add up the totals and really kind of take a look at what a hospital stay and a facility stay in a skilled nursing facility would look like. So Mr. Trumpet fell and he stayed in the hospital for 90 days, right? So his initial hospital day, he's looking at his initial deductible of that $1,340 that we went over. After day 60, he's going to stay in the hospital for another 30 days, which comes out to that $335 per day amount. So that's a nice little total there of $10,050. So if you take those two amounts and add them together, we're looking at a grand total hospital cost of $11,390. It's an amazing amount, right? But hold that thought. We do also have the skilled facility stay as well on top of there for an additional 40 days. So as I mentioned before, right, the first 20 days of that skilled nursing facility stay is going to cost them $0. However, looking at from days 21 through 40, we're looking at that $167.50 figure for each of those days. So if you're quickly doing some math on that, that comes out to $3,350 in regards to those 20 days. So what you need to now do is you need to take that $3,350 and add it into that total hospital cost. You're looking at a whopping total of just under $15,000. That's an amazing amount of money if you think about it for somebody to actually have to come up with, right? Especially somebody that might be, over 65 and just on Social Security. So, this is why it's super important to make sure that, one, you're always doing right by your client, especially when it comes to Medicare, but two, to make sure that you're doing that full needs analysis so that when it comes down to it, obviously nobody can really predict an accident or a fall or something of that nature. But when it comes down to it, you want to make sure that you're going to get them on a plan that's going to be the most cost effective for them in the end. And whether that's original Medicare or whether that's in a Medicare Advantage, a Part C plan, that's going to be why you're going to take the time and do really that full needs analysis for them. So, with that said, that's really what Part A is. It's anything that you're going to be looking at as far as any inpatient hospital or skilled nursing facility stay. So what is the flip side of that? Well, the flip side of that is going to be Part B, and that's where we're going to move into the outpatient portion. Part B in the outpatient portion is going to be basically entailing any doctor's office visits or any outpatient coverage. So if you really kind of take a look at Medicare in general and into the two parts in Part A and Part B, Part A being in and Part B being out. Pretty easy to remember in those most simplistic terms. But let's dive into Part B and see what it actually entails as we dig in deeper a little bit. So Medicare Part B itself, coverage-wise, is going to really help pay again for those doctor visits, any sort of outpatient services. And of course, it's going to also include, just like Part A did when they were in the hospital, it's going to include any sort of durable medical equipment they might need, any x-rays ordered, lab tests ordered, or possibly even ambulatory services as well. So the thing to keep in mind about this, though, Part B is optional. It is available to everyone who gets Part A, and it's offered and available to all of those individuals, but they generally don't have to take it because it is optional. We'll get into in a little bit here and a little bit later some possible penalties if they decide not to take it. Obviously, though, it is highly recommended for you to speak with them in regards to when they're first signing up that they want to definitely look at getting Part A and B together. Again, it is optional, but you always want to do that full needs analysis to make sure that you're fulfilling their needs to what they're going to require going forward. So really defined, Part B is going to pay for the doctor's services and a variety of the other medical services and supplies that aren't covered by Part A. It's hospital insurance. Something to note, though, is that most of the services needed by people with permanent kidney failure are covered only by medical insurance. So that's something to note. Now, just like Part A, right, there's a premium involved with that. Part B also has its premium. The standard Part B premium currently with the most current Medicare CMS statistics is set at $134. It is possible that they could be paying a higher amount than that depending upon their income, but the standard amount or the standard premium that the majority of Medicare recipients are going to be paying is $134 for that premium. People who do choose to, or people who do get Social Security benefits do pay slightly less than that, about $130 on average, but the standard premium at this point is set at $134. Now, what is the criteria that they have to meet in order to get that premium amount so that it's not the higher cost that I mentioned? So the covered party is going to generally pay the standard premium amount or higher as long as they meet the following criteria. And that criteria is 1, that they're enrolling in Part B for the very first time. That 2, they're not under current Social Security benefits, because if they do get Social Security benefits, of course, there's going to be a smaller cost. And 3, that they're going to be directly billed for their Part B premium, meaning basically that they're going to either get it through the mail or they're going to do it like on a quarterly billing statement. There are a couple different options for billing at that point, which we'll touch on here in just a moment. But that's really the main 3 points of the criteria that they're going to be meeting to pay that standard amount. Now, what if their income's a little bit higher, you ask, right? So generally speaking, the $85,000 income level is the cap of where that 134 amount is going to hit. So once you reach above 85,000, that's when that amount is going to start going up and up and up. Generally, the highest amount that they're paying, according to CMS figures right now, anything above 160,000 per year is going to be $428.60. It's a pretty big premium to pay, but at least at that point there is a 5-tier chart here that you can look at and at least quantify where do they fall into this range. Again, the majority of individuals that are going to be on this are going to be at that $85,000 range because generally they're either going to be on some sort of a Social Security disability, or if they are working, it's likely that the income is more than likely going to be less than 85,000. But if it is higher, you do have these 5 tiers here where, 85 to 107, 107 to 133, and so forth going up. Now, likewise, just like Part A has its premiums and it has its deductibles and it has its amounts that they're going to be paying for individual premium costs, Part B does have a deductible as well too. That deductible currently is set at $183 per year. After the deductible is met, that is when the coverage for Medicare Part B goes into what's more than likely known as like an 80-20 plan. So the enrollee is going to typically pay 20% then of the Medicare approved amount for the majority of the doctor's office and outpatient coverage costs. So again, that's defined as most of their doctor services, even possibly doctor services while they're a hospital inpatient. So let's say, for example, that the doctor on staff that's treating them for their specific injury is not their primary care physician, right? But their primary care physician does come in and meet with them in the hospital. It is possible that that caveat would then apply at that point, and those doctor services would be covered under the Part B portion. Likewise, any outpatient therapy and any durable medical equipment, that 20% is going to then be their responsibility at that point. Now, I mentioned earlier about a late enrollment penalty. So if they choose to not sign up for Part B, in most cases, if they don't sign up when they're first eligible, it is likely that they'll have to pay a late enrollment penalty. What does that penalty entail? So that penalty entails this. Anytime that you do not enroll when you are first eligible, it is very possible that you'll have to pay a penalty for as long as they then have Part B. What does that mean? It means that the monthly premium for Part B could possibly or potentially go up 10% for every 12-month period that they did not have coverage. So for example, well, again, also likewise under this is if they wait, for example, to enroll, they won't be able to sign up right away. They'll have to actually wait until their general enrollment period, which is going to be January 1st for the new OEP or the new open enrollment period, to then sign up for this portion to enroll in Part B, which then their coverage would start July 1st. But what does the penalty entail? So the nice thing about this, though, is that usually they won't have to pay that penalty if they do meet certain conditions that allow them to sign up for Part B. Those conditions are a special enrollment period. So let's say that there's a marriage or a family change or a plan change, they move. If they qualify for a special enrollment period, that's going to wipe out that late enrollment penalty. But let's say, for example, that they have to actually pay the penalty. What's that really going to entail? So as an example that I put up here is, let's say that their initial enrollment period ended September 30th of 2009. But they waited to enroll for their Part B. They opted out and they didn't enroll until March of 2012. So what does that window entail? That window entails 2 full 12-month periods. Now, even though it's not a full 3 years and it's only 30 months of between September of 2009 and March of 2012, they only count full 12-month windows. So during that window, there's only 2 full 12-month periods that they're going to be as a penalty. So in this instance, they're going to be paying a 20% premium penalty for the amount of time period that they actually have their Part B coverage because they waited to enroll. So that can actually come out to be some high dollars. So that's why again, it is optional for them to enroll in Part B, but it's really a good thing to encourage them to enroll just to ensure that they don't get the late enrollment penalty. Again, though, if they do qualify for a special enrollment period, then that penalty would be null and void. Some of the things that you're going to get under the Part B umbrella as far as coverages and any cost sharing is that once the deductible is met, they're going to get their doctor services, outpatient, their home health, other medical and health services, and also things like prescription drugs, which is very limited. And let me kind of explain that a little bit. So Part B and Part A themselves don't really have prescription coverage. That's what Part D is going to be about, that we're going to dive into next week. But let's say, for example, that you go into a doctor's office for a visit and the doctor needs to give you a shot of antibiotics. Or let's say that, like, for example, I go into my healthcare professional and I get vitamin B shots and vitamin B plus complex shots. Those would be covered under this as long as it's something that's being given in the doctor's office and that's being prescribed by the doctor. So they can't generally go into a pharmacy and get coverage with this, but in the outpatient setting, and similarly, just like on the inpatient setting where the drugs are covered under Part A, but in the outpatient setting of Part B, that's when those prescriptions would be covered. So that's a nice little thing that's in there, so that that's actually fully covered at their cost at that point. So then also some outpatient treatment for things like mental illness, and then there is a wellness plan that's available as well too, that's going to have coverages and cost sharing on that. So this chart here is actually provided by CMS. It kind of breaks down each of those individual sections that we just kind of went over regarding, for example, Medicare or medical expenses. Medicare is going to pay for medical services in or out of the hospital at 80%, as long as it's an approved amount of the Medicare covered services. So after they pay that deductible, it's going to be where that 80-20 pops in. And then their deductible plus 20% of that amount is their cost. Likewise, with clinical laboratory itself is generally paid at 100% of the approved amount. Home health care. Now, outpatient, for example, it is unlimited as long as it's medically necessary, and Medicare payments to the hospitals are based on that. But then 20% of the billed amount after the deductible, of course, is going to be applied. So they can go unlimited as long as it's medically necessary, but there's going to be a 20% portion that they're going to be paying. Likewise for blood, 80% of the approved amount after the deductible, of course, but it does start with the 4th pint, so those first 3 pints in that aspect. Now, this area itself is kind of a repeat of what we just discussed, but there's a couple things in there that I wanted to point out. Some of the things in here is that most of the outpatient prescription drugs are going to be excluded. So private duty nursing is going to be excluded. Any intermediate nursing home care is going to be excluded. Anything above any of the standard physician charges that Medicare is already paying is going to be excluded as well. Likewise, any care that they get outside of the United States is going to be excluded, which, as we get into later series, when we start talking about things like Medigap and even like NatGen's plan, for example, actually covers things that happen on the outside of the United States. So that's always where you can add on and add on and add on as far as those supplements are concerned to really kind of fill those gaps. Anything that's dental related or eye related is generally excluded from this, except in the cases of, let's say, for example, that there is an accident and there is an emergency need for a dental need. That's when that Part B is going to cover that because of that aspect. And or even if Part A might cover it if it's something that's being done on an inpatient hospital basis. Things like hearing aids, orthopedic shoes, acupuncture are also excluded, as well as anything incurred due to an active war or a current ongoing war. Now, as far as enrollment is concerned, individuals will have 7 months to enroll for their first time in Medicare. So what does that 7 months entail? What it entails is the first 3 months prior to the month of the effect of when they turn 65, and then 3 months post their birthday month. Once they're enrolled, though, they will have an option to change plans annually during the AEP that's upcoming. But what that 7-month window looks like is this, and this is an amazing graphic in the fact that those first 3 months, those last 3 months, and then the month of their 65th birthday. So they have a full 7-month window to initially enroll for Medicare itself. Now, the nice thing about Medicare is that enrollments, a lot of times, even like 8 or 9 times out of 10, it's actually going to be an automatic enrollment. And what does that entail, right? So once they are turning 65, if they are already receiving Social Security, or if they're a railroad retiree and they were getting their railroad benefits, they're automatically going to be enrolled into Parts A and B. They're going to receive an initial enrollment package within that first 3 months prior to their month anniversary of their 65th, their birthday month, as well as the fact the same thing applies for anyone that's under age 65 and possibly receiving an SSDI. So if there's somebody that's under the age of 65 and they have a disability and they've been on SSDI, they are going to be automatically enrolled once they reach months 23 and 24 within their SSDI coverage. So likewise, as far as Social Security and the railroad, they're going to get that initial enrollment package about 3 months prior to that 25th month coverage. So what they'll happen is they'll get automatically enrolled in months 23 and 24, and then they'll get that initial enrollment package about 3 months prior to the actual effective date of that month. Now, if they're turning 65 and they're not yet signed up for Social Security, what they're going to need to do is they will need to contact Social Security up to about 90 days prior to their birthday. And they can contact Social Security by calling that number. They can actually visit their local Social Security office and then enroll at that point. Something to keep in mind is when you're discussing this is that they are going to need some information. When they enroll, they're going to need their Medicare claim number and any effective dates for Parts A and B. So likewise with railroad retirees, they should contact their railroad retiree board as well too for their benefits, which that number is posted there. So the number for Social Security, 1-800-772-1213, and for the railroad is the 877-772-5772. So after they enroll, like I mentioned earlier, they do have a couple different ways that they can actually pay for that. One, automatically deducted from their Social Security check. Now, if you remember earlier, if they are doing the Social Security, there's going to be a slight adjustment there. However, they do offer automatic deductions for any of the railroad retirees that are earning a pension, as well as any federal government employees that are earning a pension as well. Those are automatically deducted. So it makes it really easy on those individuals to not have to worry about each month or each quarter making a payment to their premium. It's going to be automatically deducted. Now, if they're just under the standard Medicare and they're not getting any sort of automatic deduction, there are a couple different options that they have. One of those being that they are allowed to be mailed a quarterly billing statement, which at that point that they will then make their premium payments through the mail. There is also an easy pay option that Medicare offers to deduct from the bank account through what would be normally referred to as like ACH or EFT, as far as the automatic clearinghouse and the electronic funds transfers. So they have those options available to them as far as payments are concerned. Now, that's really Medicare Part A and Part B in general. I know it's a real high level overview. There are some other deeper areas that we can certainly dive into if you have other questions, but in and of itself, at its core, Medicare Part A and B are really just 2 words: inpatient, outpatient. Inpatient being Medicare Part A when they're in the hospital or in any sort of a skilled nursing facility, and then outpatient being Part B for things like any outpatient care or rehab or doctor's office visits. So pretty easy to remember if you just think of it in those two terms and those two words of inpatient and outpatient. And then that kind of puts everything in perspective at that point. Now, if you or the enrollee has any questions about Medicare, they can always go directly to the Medicare.gov or the CMS.gov websites. I don't know about you, but being in the Medicare field, I tend to live and die by the CMS site. I'm on it. I know it like the back of my hand. I probably know it better than some other websites that I use, like to read the news. And while that's, really good to know, it is a good thing to keep in the back of your mind as far as a resource that you can refer them to. And also, if you just want to learn more as well, the CMS.gov and the Medicare.gov sites are full of just wonderful resources. And I would highly encourage anyone that has any additional questions to not only reach out to me and or our training team, but take some time to explore those two sites, because they have training areas and they have learning areas where there's videos and they actually break down individual parts and even dive really deep into the specific coverage types. So those are some really, really good, amazing resources out there for you to learn more. Obviously, when in doubt, Medicare.gov and CMS.gov are always going to be your main sources, but they can also call 1-800-MEDICARE to reach their contact center to get additional information as well. And then for any Social Security Administration questions, for example, for the LIS, like if there's a low income subsidy or if they need extra help paying things like their prescriptions, they can go to the SSA.gov site. Well, with that said, that is Medicare Part A and B. Wasn't too hard, right? Really easy, really quick. And really, if you look at it again, just in a high level overview, it's really just two things, in and out. And if you just kind of keep that in mind, and the main thing to keep in mind when you're really getting those needs analysis done is to make sure that you're really kind of diving deep down and asking the questions that you need to, so that you can securely and know that you're going to be putting them in a plan that's going to be doing right by them and fit their needs as the best as possible. So as always, if you do have questions, feel free to reach out to our training team. You can go to training@ahcpsales.com. I monitor that box. Our other trainers monitor that box as well too, and they will try and get an answer to you as quickly as humanly possible. Cheers, everybody.